Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision, the standards, and the culture of healthcare systems. If you want to join in the conversation or learn more about activating physician leadership, go to license2leadpodcast.com, where you can send me an email or even leave me a voice message. I'd love to hear from you. Hi, everyone. Thank you for joining me here on the License to Lead podcast. This is Patty Fay. A few months ago, I sorted through whether physician leadership and physician burnout is worthy of focus in the context of the COVID crisis. Well, that was an easy yes, especially while watching the disregard for healthcare workers, the silencing of physicians who sought to do their jobs and protect their coworkers and patients, and the scramble by CEOs to preserve their reputation and their profits rather than focus on their patients and staff. Now we're watching healthcare systems with billions in reserve take billions more of our tax dollars, pay executive bonuses, and lay off healthcare personnel, those suddenly inexplicably not so essential workers, I guess. So yes, the discussion of new leadership is essential. And now, is our dysfunctional healthcare system a worthy focus after the George Floyd murder? This massive mobilization has made it impossible to not see pervasive institutionalized U.S. racism and entrenched police racism and brutality. I do think driving for different leadership in healthcare is relevant. Healthcare systems are racialized institutions with racially disparate treatment and outcomes. Often the leadership is financially focused, not clinically focused, not care and caring focused. White men are at the helm and fill the C-suites of the vast majority of healthcare systems, with people of color and women overrepresented in lower paid service roles. There is more hope for transformation, for naming and eliminating racial inequity if healthcare is led by those with a professional commitment to health and healing. And do I think that's a slam dunk? No. But I am hanging my hat on the dramatic shifts in medical school demographics and politics. More than half of medical students are women. Almost half are non-white. The percentage of Black students has been slowly increasing. And there's been a marked shift to the left among young physicians, with only 19% of trainees who identify themselves as conservative. So in this episode of License to Lead, I'm offering up my take on why we haven't much moved the needle on physician burnout. It's painful to paw through the documentation and redocumentation of the degraded work lives of physicians year after year of hand-wringing over burnout statistics interspersed with a kind of chirpy hopefulness if, for instance, only 44% of physicians are burned out, not 50%. We have clear and convincing descriptions of the causes of burnout. We don't have a lot of action directly tackling those causes. Why are we so stuck? If you've been listening to the License to Lead podcast so far, you'll know that the flag I wave is the lack of physician leadership of our healthcare systems, the lack of physician autonomy, and a pernicious BSM, business school mindset. All right, no, I don't expect that anyone is going to embrace my acronym. But the business school mindset embraces managerialism, monitoring and measuring with financial tools that care not one bit if the organization is a startup with a new app, a big box hardware chain, or a safety net hospital. Managerialism prioritizes profits over patients and treats physicians like commodities that must be monitored so throughput and revenue collections can be maximized. And you know what? We've been sitting on this for 20 years. A 2003 JAMA article titled Change in Career Satisfaction Among Primary Care and Specialist Physicians looked at physician career satisfaction from 1997 to 2001. The authors, Bruce E. Landon et al., explained the real causes of doctor dissatisfaction. Quote, rather than declining income, threats to physician autonomy, to their ability to manage their day-to-day patient interactions and their time, and to their ability to provide high-quality care are the most strongly associated with changes in satisfaction, close quote. In this podcast, I'll give my take on the situation, why we're stuck without useful roadmaps for how to restore support and sanity and safety to healthcare organizations. I'll talk about 4 areas. First, the weak language people who have the podium are using. They're using their indoor voices, not their bullhorns. What's with that? This is important. Number 2, data disconnection. What is known about burnout is ignored, and the proposed solutions are divorced from the evidence. The third issue is the substitution of the term well-being for the term burnout. It's understandable, given what a pleasant topic well-being is, but it's inappropriate. I'll talk about why. The fourth issue is the biggest issue, the ultimate cause, leadership, the failure of those in leadership to take on the critical, very challenging, and very expensive issue of addressing burnout. All right, up next, we'll get started by talking about the weak language we use when talking about burnout. All right, part 1, weak language, bearing the lead, and gobbledygook. Physician burnout is a career-destroying, patient-harming, expensive issue. And yet those with the microphone, the corner office, and the publications don't seem to be inclined to be loud and clear. In fact, alarming statistics are often couched in bureaucratic language or not addressed at all. So is it politically charged for those who are writing about it from their secure posts within the status quo? The 2013 RAND study was excellent and thorough. The top 2 findings were that docs were thwarted in their ability to provide high quality of care to patients and that the dysfunctional EHR was problematic. The study gave us a map and a destination, and we could have been on the right road for the last 7 years. But it didn't get much traction. After an initial press release, I didn't notice that the AMA did much to hammer home the points, and I don't know if RAND felt like they had a dog in this fight, but I didn't see fanfare from them either. In a 2017 Mayo Clinic Proceedings article titled Professional Satisfaction and the Career Plans of U.S. Physicians, Sinsky et al. Identified the fact that at least 20% of physicians intended to reduce hours or leave their current position within 24 months. And all this voluntary attrition would make it impossible to meet the projected U.S. demand for physicians in 2025. Why were the docs bailing out? 2 of the independent predictors were burnout and dissatisfaction with the EHR, the electronic health record. So this was a specific linking of physician turnover, which is extraordinarily expensive, to the dysfunctional EHR. This is the kind of data that should have had the CFOs racing to their spreadsheets to calculate the ROI on fixing EHRs. The organizational costs associated with physician turnover are almost $1 million per departing physician. Well, there was no racing, apparently. Maybe the lack of fanfare was predicted by this lackluster closing statement by the authors. Quote, concerted efforts are needed to address these issues at the national and organizational level to preserve the adequacy of the physician workforce, close quote. Concerted efforts to preserve the adequacy, well, that was all very restrained. The lead author of the article is Christine Sinsky, MD, who's the Vice President of Professional Satisfaction at the American Medical Association. She also serves as a director for the American Board of Internal Medicine. Here's another similarly restrained comment, quote, a physician workforce that has one eye on the door may not be optimally engaged and aligned with advancing the institution's goals, close quote. Well, now that's an astounding level of understatement. Physicians can't wait to jump ship. We know that. And studies in all sorts of industries make it clear that people who are angling for the door not only are not engaged, they're likely to reduce the engagement of people around them. They may even sabotage the organization. This would have been a legitimate place to launch the flares. This data points to big dollars. We missed the opportunity to get stirred up and launch the flares when it was just, emotional exhaustion, cynicism, despair, and suicidality. But this, on the other hand, is big dollars. But it's that messy, complex people stuff, and it's a long-term view. If it's not a line item on this fiscal year's spreadsheet, when it comes to a business school mindset, it just might not exist. A lot of the medical literature on burnout tends to be understated to the point of shriveled. Now, I could understand this if the research is about comparing NSAIDs or slight improvements in recovery time after posterior versus lateral approach to some orthopedic procedure, but this affects all of us. This is the medical profession. This is access to care for patients. This is billions of dollars attributable to physician turnover. This is not the place to be the impassive scientist. In an article titled Physician Suicide, A Call to Action, the author recites the catastrophic statistics associated with mentally healthy people who are just about to start medical school, who are then transformed into mentally unhealthy medical students with high rates of burnout and suicidality. The author says, quote, "There seems to be something inherent to medical school that contributes to reduced quality of life and emergence of mental health conditions," close quote. Yes, indeed, there does seem to be, and it's amply documented, and it's ugly. Now, is this kind of language misguided caution about sounding like a proper scientist? Or is it fear of backlash for clear statements that might mean you're putting people in positions of power on the spot to take action and cough up money? I don't know. I don't get it. Captivating writing and passion about important findings should be encouraged as long as all your numbers add up. My point here is that if we want to change anything based on the data, let's draw attention to the data. Next, I want to talk about this idea of bearing the lead. Dr. Christine D. Olson from Yale wrote an editorial in Mayo Clinic Proceedings titled Physician Burnout, a Leading Indicator of Health System Performance. In the article, she said, quote, "Monitoring physician well-being is especially important now that most physicians are employed in large organizations and may lack authority to act independently," close quote. This was the penultimate sentence in a 3-page editorial, so it's a remarkable example of really bearing the lead. How about we talk about the fact that physicians lack authority to act independently? Let's get a few of our prolific research centers addressing that intriguing topic, given that most of those physicians probably have language in their contracts that pretend to give them autonomy in clinical decision-making. Now, this editorial was about burnout and whether or not burnout should be a leading indicator of health system performance. But guess what? Autonomy is a central, a core, a critical component of physician satisfaction. So there we are, bumping right up against the reason for this podcast in the first place: physician leadership and physician autonomy to drive an excellent culture for everyone. I don't think we should accept that, as Christine Olson said, quote, "Physicians are employed in large organizations and may lack authority to act independently," close quote. I think that this is at the very heart of the burnout issue. Another example of the lead getting buried is the 2013 RAND AMA study on physician satisfaction. By the way, did you know RAND stood for Research and Development, R&D? Me neither. The researchers looked at 30 practices of various sizes and ownership structures in 6 states and conducted surveys as well as in-person interviews. The study has 10 findings, but 2 that were highlighted as critical and novel findings causing physician dissatisfaction. The first was that physicians faced barriers in attempting to do the work of providing high-quality patient care, and the second source of dissatisfaction was the dysfunctional EHR. So those were the explicit in-your-face barriers or proximate causes of dissatisfaction. RAND's third and fourth findings were autonomy and practice leadership. So physician autonomy was important for professional satisfaction, and physicians owning and leading their practices were important drivers of satisfaction. And specifically with physician leadership, you might wonder, what was it about physician leadership that increased satisfaction? It was alignment of values, and then back to number 3, the leaders associated with greater satisfaction tended to preserve physician autonomy. So you can understand my attention to these findings. The core themes of this License to Lead podcast are physician autonomy and physician leadership. My interpretation is that these are overarching concepts that RAND AMA could have led with. Physician autonomy and physician leadership are the structural framework needed to create physician satisfaction. So there it was back in 2013. I wish RAND and the AMA would have used their outdoor voices on this one. So far in part one, I've talked about weak language, the tendency to bury the lead on issues of central importance to this issue of physician burnout, and next up, gobbledygook. An area that makes my eyes glaze over is the bureaucratic, undecipherable language and hopeful generalizations of white papers, position papers, commitments, calls to action, and charters. Here are a few, and this is just the tip of the iceberg. 1, a 2017 Charter on Professionalism for Healthcare Organizations. 2, a list from Mayo titled Executive Leadership and Physician Well-Being, 9 Organizational Strategies to Promote Engagement and Reduce Burnout. 3, a position paper of the APC called Putting Patients First by Reducing Administrative Tasks in Healthcare. And 4, a 2018 Charter on Physician Well-Being published in JAMA. All of these are filled with shoulds and coulds, trust and teams, and practicing, prioritizing, and promoting. I can't point to one of these that's a little better or a little worse than another. But here, I'll give you a couple representative sentences. So from the Charter on Physician Well-Being, this is under organizational commitments. Quote, leaders could establish physician well-being as an organizational priority by including well-being initiatives in strategic planning efforts, using organizational awareness strategies to better identify and respond to emerging well-being challenges, and integrating well-being measures into assessment of organizational performance, close quote. Not a word in that Charter on Physician Well-Being about autonomy, much less physician leadership. And here's a sentence from the ACP document, quote, the ACP calls on stakeholders external to the physician practice or healthcare clinician environment who develop or implement administrative tasks such as payers, governmental and other oversight organizations, vendors and suppliers, and others to provide financial, time, and quality of care impact statements for public review and comment, close quote. The work on this ACP policy paper started with literature reviews in 2014, and they published their work in 2017. I think these charters and declarations are at best neutral, but not even neutral because of the opportunity costs for the people around the table. I think they are at best neutral because they don't state in clear, concise language what must be done, why, by when, and by whom. This increases cynicism. And it's that sing-songy bureaucratic language that makes me want to stab my eyes out. Next up, we'll talk about the data disconnect. Part 2, data disconnect. In this section, I want to talk about how data is disconnected from what's known, or disconnected from the conclusions or actions, or quite often just disconnected, like when there's survey data without any conclusions or next steps presented. We know the biggest causes of burnout in practicing physicians. So if we're going to do an intervention, let's start with what's been proven and corroborated, like concrete issues such as doctors being thwarted, not supported in patient care, and the frustrating time sink of the EHR, right? And yet, the burnout literature continues to be filled to the brim with studies and articles looking at resilience training, coaching, small group work, and mindfulness training. Usually, these solutions are presented right after a disclaimer about how burnout is, of course, an organizationally caused syndrome, and the most effective solutions will be focused on fixing the organization, not the doctor. Then, onward to fixing the doctor. A couple of physicians took exception to a JAMA article about one-to-one coaching as a strategy to reduce burnout. The article was titled, Effect of a Professional Coaching Intervention on the Well-Being and Distress of Physicians. And 3 of the article's authors were the prolific burnout and wellness researchers, Drs. Derby, Schoenfeld, and West. The 2 physicians wrote a letter to JAMA, and their critique perfectly addresses the issue. Quote, We believe physicians with burnout are primarily victims of a healthcare bureaucracy that takes advantage of clinicians' dedication to patient care, often at the expense of their own well-being. Physician burnout is largely a result of the policies of institutions, not a lack of stress management skills, close quote. The letter writers are a couple of anesthesiologists from Stanford, and they go on to point out that, of course, interventions like coaching will bump the needle in the right direction. Quote, as is the case with a patient with a curable disease who may benefit from coaching, mentorship, and peer support, but really just needs access to curative treatment, the cure for physician burnout should primarily focus on restoring direct physician control over the practice of medicine. Close quote. I agree. And how about if the powerhouse burnout and wellness researchers, these are the physicians who presumably have the reputation, the influence, and the funding, put a spotlight on and tackle the difficult solutions? I picked on this coaching article, but it's one of many that confuse the issues around burnout and contribute to the fact that we're stuck, not making any progress in addressing burnout, but just fiddling around the edges and then measuring it again. These little interventions are easy to set up, easy to measure, easy to arrange, easy to fund, and glory be, easy to get published. On the other hand, the known causes of burnout are messy, expensive, and probably politically dicey to study. And then there are the meta-analyses. Meta-analyses make sense to me if they are used to combine similar interventions to see if there's a meaningful outcome. But when meta-analyses are just an exercise in statistics without advancing the cause of fixing burnout, to me, that's just too bad. A 2016 burnout meta-analysis in The Lancet by the Mayo Group looked at 2,500 articles and narrowed that down to 52, of which 20 involved so-called organizational interventions, as opposed to physician-driven interventions like yoga or resilience training. The author's conclusion was that both individual and organizational interventions can reduce burnout. But of the 20 organizational interventions, I could only spot 3 that intervened in a physician's workflow, workload, barriers to work, or EHR, what I would consider relevant interventions. Now, why on earth does that bug me? One, it wasn't easy to figure out that this big meta-analysis did not meta-analyze studies that seemed relevant. I had to hunt for that information. And then beyond that, it seemed to be an enormous statistical exercise that didn't help the cause of identifying solutions. A worthwhile deep dive into burnout is the 334-page National Academy of Medicine study titled Taking Action Against Clinician Burnout, a Systems Approach to Professional Well-Being. Supporting my observation that there simply are not many organizational interventions to point to is the fact that the National Academy of Medicine co-chairs said they wished they could go further in making recommendations, but they were not able to provide specific recommendations for system interventions. Quote, the evidence for system interventions that significantly address clinician burnout is limited, close quote. And they went on to call for investment in research on organizational interventions. Sometimes the solutions in articles don't even map to whatever is discussed in the article. In a group practice journal article titled Physician Stress and Burnout, Danielson et al. Reported the results of a survey of physicians about their stress, and the physicians overwhelmingly said that what would help is more staff support to deal with the administrative demands. The authors then described the initiatives that were put in place. There were several, and they were related to recruiting and hiring, onboarding, and periodic wellness assessments. The docs say, I'm drowning, give me some staff support. And the published outcomes are, quick, reorganize our approach to recruitment. So I've criticized Tate Shanafelt and the gang he used to work with at the Mayo Clinic, but they're well known and they've earned their sterling burnout research credentials by publishing most of the high-profile burnout statistics that are cited in the literature. Not only the rate of burnout across the specialties, but the rate of burnout across time and comparisons of physicians to the general population. and to other highly educated professionals. This has been critical data to have. One of the best studies from this group, with Schanefeld as the lead author, was a 2015 article titled Impact of Organizational Leadership on Physician Burnout and Satisfaction. This study of Mayo physicians clearly links burnout and satisfaction levels of physicians to the behavior of their departmental leaders. That takes the research beyond just descriptive statistics into an actionable area of leadership development and leadership intervention. And now I think it's time for Tate and the research gangs at Mayo and now at Stanford, his former and his current CEOs, and other high-profile people to use their status and influence to get budget dollars directed at real interventions to support physicians to take excellent care of patients. Dr. Christine Sinsky of the AMA said that 70 to 80% of physician work output could be considered waste, defined as work that doesn't need to be done and doesn't add value to the patient. And the EHR has been cited as the biggest driver of dissatisfaction. So please throw your researching selves and the influence of your institutions at that. 70 to 80% of what physicians do doesn't need to be done and doesn't add value to the patient. Next up, we'll talk about well-being. Part 3. We are barking up the well-being tree. So this episode of License to Lead is looking at why are we stuck in addressing burnout? Why are we not getting this resolved? I'm taking a shot at it, but I hope to learn more from listeners, in which case I'll update this in a future podcast. So I've talked about weak and unclear language and research that is simply descriptive without solutions, low-value so-called research, and burnout interventions that are disconnected from the burnout data. What about this well-being concept? Well-being language, not necessarily well-being itself, but the language is metastasizing all over the place, so it does deserve a special focus. You've likely been exposed to well-being concepts, initiatives, surveys, and even some new well-being executives. I think the well-being and wellness proponents are missing an important point. Well-being and burnout are not opposite ends of a continuum. Having gas in your tank and not having gas in the tank are on a continuum. Or having light in your room and not having light in your room is on a continuum. Well, if you have a dimmer switch, or if the sun is going down, it's on a continuum. Otherwise, it's dichotomous, but you get the picture. Well-being and burnout are related, and lack of well-being and burnout show up together, but they're not on a continuum. The opposite of burnout is not well-being. It's just the absence of burnout. You can have no elements of burnout, but not be in a state of well-being, and vice versa. Frederick Hertzberg is famous for making this point in his classic HBR article called One More Time, How Do You Motivate Employees? He described hygiene factors and motivating factors. He said hygiene factors are those things that cause dissatisfaction at work, and motivators are those things that cause satisfaction and that motivate people. Time-wasting, inefficient equipment, salary inequities, inflexible policies, and disrespectful supervisors, these are dissatisfiers, or what Hertzberg called hygiene factors. And when you address or resolve hygiene factors, you just get up to neutral as far as workplace satisfaction. And if you don't get up to neutral by fixing the broken hygiene factors, don't bother with motivators. Recognition or other motivating efforts won't help and might hurt if you haven't fixed the hygiene factors. And when it comes to motivation, you can't get there from here if your supervisor is disrespectful or your salary is unfair. So fixing hygiene factors does not motivate employees. And importantly for this discussion, adding motivators or wellness initiatives doesn't fix hygiene or burnout factors. So if the number of clicks, pre-authorizations, and clerical tasks are exhausting or even disgusting, wellness interventions are not going to help. A wonderful March 2020 JAMA article titled Professional Dissonance and Burnout in Primary Care with lead author Sumit Agarwal used focus groups to identify sources of burnout and notably to identify solutions. The solution orientation of this intervention was refreshing. To this point about well-being efforts, the authors said, quote, participants uniformly agreed that personal training in resilience was not something they needed, close quote. Can't you almost get a visual of study participants in unison waving off the yoga and incense? What these physicians did need, just like their primary care colleagues all over the country, was help overcoming the organizational barriers to taking excellent care of patients. Sumit Agarwal and his 3 co-authors, all from Harvard Medical School and Brigham and Women's Hospital in Boston, identified areas causing dissatisfaction and burnout, and they detailed 8 specific areas for intervention. Another article that I thought was excellent zeroed in on the hygiene factor versus motivating factors and the parallel we see with burnout and well-being. This was a 2016 study with lead author Iris Shrivser from Stanford. Using survey data and focus groups, the researchers dug into the nature of the physician's experience, including their experience of well-being versus burnout. Shrivser et al. Made the point that for physicians, intrinsic motivation and fulfillment are intrinsic to their profession, but external pressures can frustrate doctors in their efforts to provide care, and that gives rise to burnout. Quote, thus, prevention of burnout and increasing physician wellness become somewhat separate targets that benefit from different, albeit complementary, approaches, close quote. This is important because I think this basic misunderstanding underpins many of the formal wellness programs and well-being initiatives. Why else would there be such a lack of concrete funding and rock-solid initiatives to address the very clear causes of burnout? It's like what's being said is administrative work overload, barriers to taking care of patients, and the EHR are huge problems. And what is being heard is we need a wellness program, more studies about resilience, and for sure, a chief wellness officer. In healthcare, at least, causes of burnout are specific. To mitigate burnout, you have to address the specific factors that are right there in your face causing the burnout. And well-being factors are general. To increase well-being, there are lots of options. We can compare burnout to cardiomyopathy or heart failure. Heart failure is not the opposite of physical fitness. Heart failure is specific and requires clear, sometimes dramatic, and expensive interventions. On the other hand, physical fitness is a general state related to well-being and which presupposes the lack of a life-threatening illness. And people can arrive at physical fitness in a huge number of ways. All kinds of diet, exercise, and lifestyle programs will improve someone's fitness. But if they start out with a cardiomyopathy, the need to attend to the life-threatening condition is obvious. Burnout, like a cardiomyopathy, is career-threatening, health-threatening, and in extreme cases, life-threatening. Its causes need to be addressed. So why do wellness coaches, well-being committees, and chief wellness officers seem set on tackling burnout by increasing wellness? Well, hell, well-being is a piece of cake. It's joy and music and self-actualization and that profound quiet you can experience after meditation. Who the heck wouldn't want to be a chief wellness officer, provided, of course, that well-being initiatives are actually what's needed and wanted? However, it's probably not quite as attractive if the job that needs doing, and I think this is the job that needs doing, is a crusade against the structural defects that trap people into a daily routine of illegitimate work that allows no recovery from the all-out sprint of a chaotic practice. If the job is figuring out a fix to the budget-sucking behemoth EHR, or figuring out how to give physicians actual time to think, as opposed to teaching them to be more resilient given the fact that they have no time to think, or if it's taking on the CFO who thinks he's the only grown-up in the room who likes to say, now, Dr. Fay, the pie is only so big. If the job is those things, the list of eager candidates for chief wellness officer might dwindle. Certainly the likelihood of success will dwindle. Why? Well, who could handle that responsibility? There's only one position where the odds of success are good, and that's the CEO. Securing an adequate budget, taking on the business school mindsets in the C-suite and on the board, where, frankly, the members may not see that there is a problem, that is not what wellness officers appear able to do. The patient with the cardiomyopathy isn't doing well, can't breathe, she's suffocating, and you can plan to offer her a few well-being initiatives, but what's actually needed? A heart transplant. And that requires a different level of authority, expertise, funding, equipment, and personnel. I mean, get the incense out of the sterile field. There's a life to be saved here. Up next, let's talk about leadership. Part 4, The wrong leadership revealed. There's that joke about the guy who lost his car keys in a dark alley, and he was out on the street under a big streetlight, frantically hunting for them, when a buddy comes up and asked him what he was doing. So he explained, and his buddy said, "If you lost them in the alley, what are you doing looking for them here?" And he said, "Well, because this is where the light is." I'm afraid when it comes to burnout, physician career, the dysfunctional technology, the business school mindset prioritizing profits over patients, we got a bunch of people looking under the streetlight trying to find the easy answers, avoiding the threatening and difficult unknown where the real answers are. The leaders are issuing position papers and commitments, creating new administrative infrastructures, building out vast websites with training and development curriculum, and fostering robust research careers, all based on looking in the wrong place for answers to what's destroying medical careers. Our hospitals and healthcare systems have the wrong leadership by definition if they haven't aggressively tackled burnout. Now, with all the changes and pressure brought on by the COVID-19 crisis, there's a high-profile opportunity to size up the values and priorities of healthcare leaders. Are they clearly supportive of their staff and of the physicians? What is the leadership behavior during the crisis? Does a concern for public relations and for securing their own financial well-being trump concern about the lives of caregivers and for patients, for that matter? In addition to the healthcare systems and hospitals, there are other influential organizations that have a profound impact on physicians and others. The specialty and advocacy associations, the organizations that oversee and control rules and regulations for medical schools and graduate medical education. Too often, these organizations appear to have a profiteering or business school mindset. They've decided that the organization they're leading wins by using the standards of the business school mindset, control and monitoring, and selling products and building infrastructure and securing a large margin, rather than seeing themselves as guiding a service organization serving the best interests of medical students or residents or physician specialties. Many of the so-called advocacy organizations are reviled by doctors because of the perception that they, frankly, have been corrupted by their own business school mindset, increasing their own organizational bottom lines and securing perks for themselves rather than serving the medical profession. The AMA is a primary target. The number of voluntary dues-paying members is reported to be less than 20% of practicing physicians. The AMA does not represent the majority of physicians. The NBME, or National Board of Medical Examiners, charges exorbitant fees for medical student testing, turns a deaf ear to complaints from all sides regarding the onerous and counterproductive Step 1 exam with its questionable validity. The CEO of the National Board of Medical Examiners permitted everyone to see his arrogant, hierarchical, outdated mindset when he responded disrespectfully in writing to recommendations for changes to the Step 1 exam. Peter Katsouforakis, MD, ouch, that hurts to say, MD, receives a 7-figure salary, the beneficiary of exorbitant fees for testing, paid for by stressed and indebted medical students. Ugh. I'll just stop. This is a podcast in itself, honestly. Next example, the American Board of Medical Specialties, ABMS, defends what is seen as a profit-motivated maintenance of certification program. They press on with maintenance of certification programs despite lack of evidence to justify what's seen as extortion by many physicians. It might seem that a blanket indictment of leadership is radical or wrong-headed, but the current state has been created and sustained by these leaders, whether they're physician leaders or not. And they're not evil, they are the status quo. As Deming said, every system is perfectly designed to get the results that it gets. If we want different results and different systems, we need new leadership. Over the last few decades, medicine has shifted to a model where approximately 95% of hospitals and healthcare systems are run by non-physicians, usually people with business degrees. Over this same period of time, what have we seen? Commoditization of the profession, discounting of the value of other staff and clinicians, an extraordinary profit motive with supersized salaries among CEOs, Byzantine billing practices which confuse patients by obscuring real costs, and decades of disregard for physician burnout. 10 healthcare system CEOs and the CEO of the American Medical Association put their heads together at AMA headquarters in Chicago in 2016 to discuss burnout. And then they published Physician Burnout is a Public Health Crisis, a Message to Our Fellow Healthcare CEOs. And this was published in 2017 in Health Affairs. So that was more than 3 years ago. So that's one thing. And then the other thing is the fact that this was called a call to action is downright cringeworthy. They presented their call to action by saying, quote, addressing the issue of burnout is a matter of absolute urgency, close quote. There was not a real action item on the entire list. Here's a follow-up comment from a physician on the Health Affairs website. Quote, measure, evaluate, emphasize, encourage, educate, track. My word, are you physicians or not? Have you forgotten how to fix anything? Well, for the record, 4 of the CEOs were not physicians. But this was a list of 11 items under the title CEO Commitment and Call to Action. And I'm not making this up. The first 3 were regularly measure the well-being of our physician workforce. Where possible, now this is number 2, where possible, include those measures in performance dashboards. And number 3 was evaluate and track the institutional costs of physician turnover and retirement. Here's another comment from a physician on the Health Affairs website. Quote, but why have physicians lost autonomy, lost control over their own work, become subject to quality measurement that often lacks a good evidence base and that fails to measure most of the important aspects of medicine, and become forced to use badly designed and implemented EHRs? I don't see any answers to those questions, close quote. The comments were rich, along with several sharp rebukes of the AMA. The fact that one of the authors was the CEO of the AMA no doubt triggered a few of the respondents. But what was utterly missing from this list is any action items to clearly fund and address the known factors causing burnout, for instance, or any alarm about managerialism, the institutionalization of a profits over patients mindset that drives the cynicism and moral injury. There was no mention of physician leadership or physician autonomy or authority, for instance, the needs for physicians to have a level of authority commensurate with their level of accountability for outcomes and a level of authority commensurate with their level of responsibility to patients. What might this list look like if it was more interested in advancing the cause of excellent patient care and excellent physician career? Well, I'll take a stab at it. Number 1, we, the undersigned CEOs, commit to sharing our annual physician burnout and satisfaction data, as well as the level of investment and the interventions to address burnout. Number 2, at each of our 10 systems, we've committed $1 million for initiatives in the next 18 months to knock down barriers in primary care departments. Number 3, implement a best practice scribe program in at least 25% of primary care practices within 18 months. Number 4, survey the extent to which physicians agree that they're doing physician work and that they're well supported to provide a high quality care to patients. Number 5, intervene to improve departmental leadership if burnout rates exceeds 32%. Number 6, 20% of our CEO compensation will be placed at risk based on 3 specific organizational burnout targets. Number 7, CEOs will share all above-mentioned measures and results. Number 8, all the assessments and interventions and measurements and results will be reported in a standardized format, administered by a third party and published on an independent website created for this purpose. My obsession here with third-party oversight of the data and the format is due to the abundance of articles that don't seem very interested in being useful or transparent, but seem much more interested in being self-promoting. Before I move into the wrap-up of episode 7, one other leadership concern I have is related to the AMA. A statement they released made it seem they don't fully understand the fiduciary responsibility of physicians. Early in the COVID crisis, when some physicians were being disciplined for making public comments about the need for PPE, the AMA released a statement saying, quote, the AMA backs physician freedom to advocate for patient interests, close quote. So did that need saying? Most of us thought that was a professional oath we committed to long ago. So it was phrased this way. In these cases where hospital conditions or policies conflict with the best interests of patients, Thank you, Stephen Colbert. The American Medical Association calls for reinforcing the principle that places patients' welfare as the first priority in any situation where the interests of physicians and hospitals are in conflict. All right, so in the AMA's statement, they're pointing to those cases where hospital conditions or policies conflict with the best interests of patients. Now, isn't that the story? Of course, physicians have an obligation to patients, so that's a reflex. Hard to imagine how that could be more clearly demonstrated than the phenomenal efforts of physicians and other healthcare workers during the COVID-19 crisis. So how about the AMA get worked up about the fact that it has become some kind of a given that hospital policies will conflict with the best interests of patients? Now, of course, if you listen to podcast number 1, you know that it's my belief that it's not legal to restrict the autonomy of physicians to act on behalf of their patients. In other words, adhering to the fiduciary responsibility that physicians have to patients. At least it's not legal in some states where there's statutory language prohibiting anyone from interfering with the physician-patient relationship in this way, for instance, in California. So throw yourself into that conversation, AMA. That would be really useful. Up next, my conclusion. Episode number 7, conclusion. All right, the causes have been clearly identified. Study after study, survey after survey, explaining that physicians have a crushing workload, are not doing physician work, they're thwarted, not supported in doing the work of patient care, and the EHR is destroying the medical careers of many. Physicians lack autonomy, lack independence, and lack leadership of their profession. Family medicine physicians and internists in particular deal with workloads that cash in on a physician's extraordinary work ethic and professional obligation to patients. Workloads, reimbursement, and levels of staff support that are so patently undesirable that medical students are routinely and frantically warned away from considering these specialties. Here are some recommendations. Number 1, to the researchers, use the data about organizational causes of burnout to create your studies to intervene in addressing burnout. Stop looking under the streetlight for the easy, cheap, and very publishable answers. Stop already with the wheelbarrows full of articles slicing and dicing burnout statistics or doing detailed statistical analyses just because you can. These efforts have opportunity costs, and they confuse the issues about the etiology of burnout, and they dilute the important studies focusing on eliminating the organizational causes of burnout. Number 2, to the well-being proponents and organizational leaders. Well, I guess we're all well-being proponents. I'm just not a well-being initiative proponent when there are structural barriers in place causing burnout and driving physicians away in droves. I'd say please stop with all the well-being recommendations in the face of physicians who are double booked during the day and doing data entry at night and who are otherwise relentlessly commoditized. Please shift to going after the sponsorship and the budget to transform the leadership and autonomy of physicians, transform the workflows and work lives of physicians so that they become well-supported leaders of high-functioning teams. And replace the EHR with technology that creatively and amply supports, enhances the physician-patient relationship. Number 3, for medical school and residency leaders and deans, I addressed these issues in podcast episode number 6. We know viable, proven alternatives to the status quo that reduce anxiety, burnout, and harm, and increase adult learning. Again, what's missing is adoption and implementation. Stuart Slavin's June 2019 article in Academic Medicine is a great place to start. Every dean and medical school leadership team should be pressed to implement the known interventions that reduce stress and increase adult learning in medical school and residencies. All right, and here's a final aside. I noticed that the California Medical Association is partnering with Stanford in a multi-million-dollar physician wellness program. Here are a few sentences from the CMA announcement. I have to say this does not reassure me that the two institutions plan to aggressively address the known workplace barriers that cause burnout. Here we go. Quote, "The program will utilize a population health framework to address systemic contributors to physician burnout, along with providing tailored support for physicians at increased risk or experiencing specific challenges. In addition to creating tools to support changes that the healthcare system can make to increase physician well-being, the program will assist those already expressing signs of physician burnout." Close quote. Based on that, I'm not confident that this multi-million-dollar collaboration between Stanford and the California Medical Association is going to focus on aggressively tackling the known organizational causes of burnout. But it's not too late to turn and look the ugly, difficult, expensive, and politically dicey challenge of crumbling physician careers and burnout square in the face. All right, I'll wrap this up with a quote. I mentioned a March 2020 article I loved because it was action-oriented. It was titled "Professional Dissonance and Burnout in Primary Care" with lead author Sumit Agarwal. There was an accompanying editorial in JAMA, and clearly the authors of the editorial appreciated the article as much as I did. Here's their closing comment. Quote, "We believe the study by Agarwal et al. Exemplifies the kind of deep dive physician groups and institutions should be undertaking to unearth the local roots of burnout and professional dissatisfaction. Such an exercise undoubtedly provides important information to organizational leaders and puts the ball squarely in their court. How they choose to return it will speak volumes about how seriously our healthcare system intends to take the problem of physician burnout." Close quote. All right, thank you everyone for listening. I really appreciate it. Please send me your thoughts, and above all, and as always, thank you for all of your care and caring. To learn more about how we work with physicians and other leaders to create healthy work cultures, or to join in the conversation for future podcasts, go to license2leadpodcast.com. where you can send me an email or leave me a voice message.